Hello, everyone, and welcome to the podcast. Today, I'd like to introduce Dr. Matthew Wall. He has a PhD in cognitive and brain sciences from the University of Cambridge. He's currently the head of MRI applications at Invicro and holds honorary appointments at Imperial College London and University College London. Dr. Wall is an fMRI specialist and has worked on neuroscience research across vision, pain, psychopharmacology, cognitive neuroscience, psychedelics, sex hormones, depression, weight loss, and more. So Dr. Wall, what's your story? Could you tell us a little bit more about your background and how you first got involved with neuroscience and fMRI?
Sure. Hi, Robert. Thanks for inviting me to do this. So I did my PhD just around the kind of turn of the century. And I'm a psychologist, really. Well, that was my training anyway. My PhD was pretty straightforward psychology. Around that time, fMRI had been invented, I guess, in the kind of early mid-90s, but it was still pretty rare, and it was pretty specialized. So around that time, it was becoming a bit more common. A few more different groups at different universities were starting to get into it, and people were starting to realize its potential. And at that time, there was just a lot of excitement about it, particularly in psychology and kind of cognitive science departments, because for the first time, really, we were able to look inside somebody's head while they were doing things that we were interested in, while they were, doing language tasks and remembering stuff and doing all these cognitive processes, and we could actually see it happening inside their brain while they were doing these things for the first time, really. So that was it was a very exciting time. So I determined that I wanted to get involved in that. So for my kind of postdoctoral jobs, I decided I was going to start applying for jobs that were doing fMRI, and I was lucky enough to get one at the time. I probably wouldn't get one now, but back then there was really not many people who actually knew anything about it, and I didn't know anything about it, so that was kind of fine. And yeah, I started doing fMRI at a place called Royal Holloway, which is just outside of London. And I spent about 6 years there doing pretty interesting but kind of pretty niche work, looking at really the kind of low level visual bits of the brain, about how the brain processes visual motion. And then I did another job for a few years after that, where I was looking at pain, a pain project, trying to develop experimental models of pain for testing out new painkillers and things like that. And during that time, I started getting involved with some other work with people looking at psychedelic drugs like LSD and MDMA and psilocybin, which is the hallucinogenic ingredient in magic mushrooms. And basically ever since then, so for about 10-15 years, I've been doing kind of pharmacological fMRI work with drugs like that, and also at my company Invicro, doing kind of commercial work for drug companies where we're testing out things like new antidepressants or new anti-Alzheimer's drugs or things like that.
That makes a lot of sense. It seems like it's been an interesting journey so far. You've worked on lots of really cool things. You've got lots of years of experience with this fMRI technology that's really useful for kind of giving us a window into the brain. Could you share a little bit more detail about what you're working on now? And then also, what do you plan to work on next? I was reading that you're working on some academic and clinical research, so I'd definitely like to hear even more about the details behind that.
Sure. So we're working on quite a lot of stuff. So a while ago, we finished a big project which was looking at the effect of cannabis on the brain, and particularly on the effect of teenagers. So we scanned a bunch of teenagers that were 16 or 17 years old and a bunch of adults to compare them. So people in their kind of late 20s, because there's a lot of concern about teenagers in particular using cannabis. Firstly, because teenagers seem to like using cannabis, or at least some of them do quite a lot. And secondly, because teenagers' brains are still developing, and there's some results from kind of animal work that shows that if you give developing juvenile rat pups high doses of cannabis, then sometime later they have problems running mazes and doing all the other things that rats normally do. So there's some concern that maybe teenage use of cannabis while your brain is developing might be more of a problem than adult use of cannabis. So we did the big project on that with my good friends at University College London. And so we're still kind of sifting through all the data on that and analyzing that. We've also just finished another project, really exciting, which is on psychedelic assisted psychotherapy. So this is kind of this kind of thing has really blown up in the last few years. So I've been working for a long time with a group at Imperial College London, headed by Professor David Nutt and Professor Robin Carlton-Harris, and they've been real pioneers in developing psychedelic treatments for depression and various other things, which you know, in the last few years there's been a lot of kind of commercial interest in that, and companies have started up doing that, and psychedelic research is really having a bit of a moment. So anyway, one thing we've just finished now is a new clinical trial which is looking at the potential benefit of psychedelic assisted therapy for anorexia. So we've had a bunch of people with eating disorders, and they've been going through this clinical program of psychedelic therapy. And my involvement is that we've been scanning them, scanning their brains before and after the therapy to try and identify what's changed or what effects the therapy has on the brain, as well as, you know, in the kind of clinical sense. So another project that I'm looking forward to starting soon is we're actually about to rip out our we've been using for a while, we've been using quite an old design of scanner for my main work. We've just got the money approved to get a new one, so in a couple of weeks we're going to be ripping out the old one and getting a brand new up-to-date Siemens MRI scanner at the site where I work in London. So that's going to be an interesting project. There's going to be a whole load of testing and validation stuff that I'm going to need to do on that, which is kind of boring methodological stuff, but it's important. I'm hoping to test out some of the new software and features that they have on the new updated scanners. So I'm quite excited about that because I'm an imaging nerd at this point in my career, but that's maybe not quite so exciting work for the general public. But then we've got a new project lined up, which is ready to start once we've got the new scanner up and running, which is the next stage in an ongoing series of projects that I've been doing with another group at Imperial College London. And these are a group of endocrinologists, so hormone doctors. And they're really interested in a particular hormone called kisspeptin. And I've been working with these guys since about 2015, I think. And we've done a series of studies looking at the brain effects of this hormone. The last couple of studies have involved people with low sexual function, so low desire, low libido. We call these hypoactive sexual desire disorder patients, HSDD patients. And these projects have been particularly hilarious and fun because we've been dosing these people with kisspeptin and then trying to provoke a sexual response. So we've been showing them, you know, explicit material, explicit films in the scanner, if you like. So that's been fun, and we've got the next iteration of that coming up when we get the new scanner installed, and that's going to be slightly different because we're going to be using a group of postmenopausal women, so a group of older women, and trying to see if we can rekindle their interest in that kind of thing.
Yeah, sounds like you're working on a lot of really interesting projects across a wide variety of different spaces. I was wondering if you're allowed to share how are the results, or how are things looking in terms of these projects so far? Like, does the hormone have promising results? Does it appear to be working for the goal that they're trying it for? And same thing with the hallucinogens.
Sure. So yeah, I mean, we've done a couple of studies with the hormone now. We've done one study in women and one study in men. The men's study was particularly interesting methodologically because we actually it's quite easy with men to get an objective measure of how sexually aroused you are. There's a very obvious signal there, right? So we actually attached a small device to the appropriate part of these men, which gives us a signal when it enlarges, the device, I mean, in order to track their objective level of arousal. And we've actually found that when they were having this hormone, infused rather than placebo, it increased their level of tumescence by about more than 50%, about 56%, I think. So that was a very clear sign that the hormone was doing something. And then when we're looking at the brain effects of this stuff as well, yeah. So in both the women and the male study, we've got some interesting results there. They're quite different. So we've just got a new paper that we're working on where we're actually comparing the male and the female group, and we think that this disorder, although they have the same kind of symptoms and the same diagnosis, at least based on the brain data, it seems that this disorder might be working a little bit differently in women than in men, which you might expect, I guess, given the differences in kind of sexual behavior and stuff like that. So that's interesting. The psychedelic stuff, yeah. I mean, the psychedelic, the whole program of psychedelics research is a fascinating one, I think. And because it's been very focused on developing these drugs for clinical use, and they have this extremely fast acting and very potent kind of antidepressant effect. It seems to be, on the face of it, better than a lot of standard antidepressants that we have. But from the beginning, in the last, it's only been going about 10 years or so, but from the beginning, what's been great is that the basic science has been progressing as well. So people have been doing these clinical trials, but involving, brain imaging stuff as well, doing fMRI, doing EEG, doing other things, which is really great because it's really the first opportunity we've had in kind of neuropsychiatry, if you like, to develop a new class of drugs and to do the really kind of basic science and figure out how they work kind of alongside, if you like. So if you think about like the last major class of useful drugs in psychiatry was the selective serotonin reuptake inhibitors, things like Prozac, which came along in kind of the late 80s. Back then, we didn't really have the kind of tools that we have now for looking at the brain in the way that we can now. So it's really a wonderful opportunity at the moment to develop these drugs clinically and get them through the FDA and get approvals for them to be used clinically in a wider sense, and it kind of in lockstep, if you like, at the same time, do some basic science on these things, figure out how they work as well, which is a really great opportunity, I think. So with the psychedelics, there are lots of different effects you get with psychedelics. So you get the acute effects, which is the crazy hallucinations, which is what people use them for, kind of recreationally or for fun, and then you get this really much longer term kind of antidepressant effect or anti-anxiety effects or other kinds of effects, which persist even after the hallucinations wear off. With psilocybin from magic mushrooms, you will you get the acute effects for 5 or 6 hours maybe, and then it goes away. But the antidepressant effect seems to persist for days or weeks or even months, which is a very interesting thing, and a completely different way of thinking about dosing for psychiatric disorders. You're not taking a pill every day. You're having one treatment or maybe two treatments, and then that effect persists for months or years. So there's been a lot of work, first of all, looking at, okay, what's happening in the brain when we're under the acute effects, when people are actually hallucinating. But then there's other work which is focused on, well, how do these long-term effects work? How does this very strong, profound, acute disruption of consciousness that you get with the psychedelics, how does that then produce these longer term effects which persist even when there's no drug in the system, and there's no acute effects anymore? Why do these clinically helpful effects persist?
That's super fascinating work on both of those projects. Yeah, especially as you mentioned with the psychedelics, it seems like that's becoming a really exciting field that is getting a lot of attention lately. I think it's definitely pretty awesome that we're finding that these drugs are having these like antidepressant related effects, and then also pretty fascinating how it's not something that you need to dose every day. For example, like an SSRI, it's, as you said, it's something you might do once or twice, and it will have medicinal effects for super long periods of time, even up to months. And that's always been super interesting to me because I don't know very much about the half-life of these drugs, but I assume that they're probably being filtered out of the system well before months come along. And so it must have something to do with something that happened like during that acute phase. If I had to guess, and yeah,
So
that's super interesting.
the theory goes that what happens when you if you look at the brains of people when they're actually hallucinating, you get this really profound and strong disruption of the normal pattern of brain function. So there are lots of different networks in the brain that are always talking to each other in the normal state, you know. So there's things like the default mode network, which you may have heard of, and the executive network and the salience network and the visual network and the motor network and whatever. What this basically means is the brain functions as a set of networks or a set of modules, if you like, which are all kind of wired together but somewhat independent from each other. And what happens when you take a sufficient dose of a psychedelic is that structure breaks down pretty severely. So that organization, that hierarchy gets kind of flattened, and the networks, the areas that normally talk to each other within a network don't talk to each other quite so much, and you get much more crosstalk between areas in different networks. So it's basically a kind of randomization of the normal pattern of brain activity, and that's what produces such crazy random effects on consciousness. But we also think that that's important in driving the clinical effects, because a lot of these disorders, depression, anxiety, post-traumatic stress disorder, even things like eating disorders like anorexia that I mentioned, they're kind of characterized by quite rigid, constrained patterns of thinking and behaving. So the theory is that this kind of acute disorganization of the brain's networks, it's basically a bit like shaking up a snow globe. Okay, you disrupt the pattern that's formed, and everything settles back into a new pattern, or you get a clean slate to work with, if you like, and it allows these patients to break out of their rigid, constrained ways of thinking, and maybe develop some more functional, some more helpful ways of thinking about their whatever problems they have. Yeah, that's the theory.
I think you had mentioned earlier that they were pairing this with some sort of therapy. If the hypothesis proves to be true, I think that seems like a great time to be having therapy and developing new habits when the brain is kind of in this more like reset or plastic type of state.
Yeah, exactly. It kind of opens a window of plasticity. Yeah. And then the idea is you have the right therapy or you have the right environment that can put you on the right path again.
Yeah, that makes a lot
Exactly.
of sense.
Mm.
Kind of like overriding those bad habits.
There's a bit of a debate at the moment about whether what role the drug has and what role the therapy has. There's some people in the community that are pushing the idea, well, the therapy doesn't really matter, and it's just the drug effects, really. I'm not sure. I don't know.
I can totally see how it would be complicated to quantitatively pull out what effect comes from what part, but yeah, I'm just super excited to see the continued research on this, working working on by you and your team as well
Mm.
as other groups. And yeah, it's just an exciting time in this space.
It's hugely exciting because this year we expect, well, we hope anyway, that the FDA will clear the first kind of psychedelic treatment as a licensed treatment. So there's an organization that's just applied to the FDA to get MDMA approved as a treatment for post-traumatic stress disorder. So that's a very major hurdle to get over. getting these things through the FDA. That's drug companies work for 10 years to get their new drug, approved by the FDA. So this is a big deal. And what that means is in the US, at least, MDMA will be a licensed medicine that in theory can be prescribed as part of this therapy thing. So yeah, that's really exciting.
Yeah, absolutely. That does sound like a big deal. And do you know how long it usually takes between like that FDA application and when the FDA comes to a decision, or is that something that kind of varies?
It's a good question. I don't know, to be honest.
Oh yeah, no
I'm not
worries.
heavily into the US kind of regulatory scene.
To make a quick pivot, I was wondering, how has the fMRI imaging methodology changed over the years that you've been involved with it? I think you mentioned you started working on the fMRI when it was in its infancy, had maybe just been invented 10 or 15 years earlier.
Yeah, so when I first started working with fMRI, I was trying to process my data on these big old like Sun workstation things. I don't know, maybe you're too young to remember those. And then I got my first G5 Power Mac, which was a big step up. The really old like Apple kind of Apple Mac Pro computers that were then. But it still used to take like all day to process one subject's data, and then sometimes it would like crash halfway through, and you'd have to start again. So on the processing side, things have improved a lot. I can do, what I used to do in 2003, I can do on my that took a day in 2003, I can do on my MacBook Air in like 10 minutes now. The software that we use has changed a lot as well. I mean, it's been it's been 20 years of almost constant innovation in the brain imaging area, really. Not so much on the basic kind of physics, but an MRI scanner is an incredibly flexible instrument. So you can get a lot of different kinds of data out of it. It's a very complicated thing, but if you know what you're doing, you can program it in the right way to get a lot of different kinds of data out of it, and you can kind of subtly tweak a lot of different things in order to get different results. So that what that means is people are constantly kind of trying to innovate in that kind of way. One of the coolest things that's come along in the last 10 years is something called multiband scanning or simultaneous multi-slice scanning. So basically, MRI data is acquired in slices through the head, if you like, and with a kind of standard functional MRI sequence, it would take you about 3 seconds to kind of scan through the head and get about 64 slices or something like that to get a whole brain volume. And then some extremely clever people, I think, at the University of Minnesota realized that, well, we don't have to do the slices one at a time. We can actually do them two at a time, or three at a time, or four at a time. And we can exploit the known features of the receiving coils that we get the data from in order to pull apart signals from different slices that we get at the same time, which is extremely clever. So suddenly that means that you can get maybe, rather than scanning one slice at a time, you can do 4 slices at a time. So instead of taking 3 seconds to scan through your head, you can do it in 0.75 seconds, right? 3 divided by 4. So that means in your 10-minute scan, rather than getting one volume every 3 seconds, you can get a volume every half a second, say. And that means you can get hundreds more images in your 10-minute scan than you could before. And you can start to track things at a higher rate, right? Because you're sampling at a higher rate. You can start to track physiological fluctuations, like fluctuations related to the heart rate and breathing rate and things like that you couldn't really see before because you weren't scanning at the right rate. It's things like that have come along in the last 10 years and are still being developed and still being pushed forward that kind of make me hopeful about we haven't got to the end of this process yet. We're still finding ways that we can improve this.
Sounds like there's been a lot of updates in the field over the past 20 years. As you mentioned, the computers that you're using to analyze this data are becoming so much more powerful, and then lots of new techniques like this multi-band imaging technique. And I think it's great that the imaging techniques are improving right along with the computers.
One more thing about
Oh
that. I
yeah.
mean, the big thing now, of course, is AI, right?
Oh yeah.
So most of well, I think all of the big scanner manufacturers on their modern scanners, they now have like kind of AI systems kind of baked in, which are basically taking lower resolution, blurry, crappy MRI images, applying deep learning models to them, and basically creating sharper, higher resolution, better images using these kind of deep learning networks and things like that. And again, I think we're only just at the beginning of what these AI models can do as well. So that's going to be a huge thing going forward.
Yeah, that addition of AI to the imaging is pretty amazing and sounds like it's getting a lot of the pre-processing out of the way and a lot of it's like some of these phone cameras that we're seeing nowadays can take a blurry photo and make it clear, and it's doing basically the same thing for the brain imaging, it sounds like, and I think that's really awesome.
Yeah. I think there's as with any AI thing, the AI basically makes stuff up, right? It kind of hallucinates the details of these things. So I think it's an open question now whether these things are going to be really useful for people doing research. But for clinical stuff, I think it's amazing. Yeah, it's really cool. And that's only going to, AI is going to be in everything from now on. Like you say, AI is already in your phone, making your pictures less blurry, it's going to be in everything from now.
Yeah, it seems like as AI, the AI field continues to innovate, it'll spread wider and wider and get involved in more and more things. Another question I had related to some of the things you said already is that people are finding out how to get multiple different data streams from the fMRI machines. And so I was wondering if you can kind of just give us some background on what some of these data streams are, and what the data streams that they started with were, and then what are some of the ones that have been added over the last few years or last 10 years.
So I mean, you can use an MRI scanner in lots of different ways. So you can get really nice high resolution kind of still images of the inside of the body, which is what it's used for mostly in hospitals and clinical settings. And they're more like kind of taking a photograph, if you like. And there's various different types of those which are kind of optimized for looking at different tissues in the body. And then there's what I use it for mostly, which is functional MRI, which is more like taking a movie, if you like, and you're looking at collecting frames over time, over a 10-minute scan or 15 minutes or whatever. And then there's various other kind of modalities, like things like arterial spin labeling, which is specifically looking at blood flow, and diffusion weighted imaging, which is looking at the kind of the wiring diagram of the brain, looking at the brain's white matter and figuring out which direction the white matter fibers in the brain are going and how the brain is wired up in that way. You can do things like magnetic resonance spectroscopy as well, which is kind of like the old technology that MRI is based on. So MRI was kind of developed out of old spectrographic techniques that they still use in chemistry labs and things like that. So that's looking at different kind of levels of chemicals in the brain, different metabolites, like things like creatine and glutamate and glutamine and things like that. So you can do that in a living person, looking at these levels of chemicals in the brain. And there's various other kind of more specialized techniques that you can do as well. Plus, of course, you can combine MRI these days with other modalities. So at the place where I work at Invicro in London, we have one of a new generation of scanners, which is a combined MRI scanner with a PET scanner, so positron emission tomography, which is a completely different kind of imaging technique, which involves actually injecting radioactive stuff into people. But having that combined system is useful in certain situations. You can get both kinds of data at once from these subjects, and you can combine fMRI with electroencephalography, EEG. That's tricky because EEG and MRI data kind of interfere with each other a bit. But you can do that. In fact, some of my colleagues at Imperial have just done this really cool study where they were looking at another psychedelic drug called DMT, which is very short acting, very fast. Gives you a trip of about 10 or 15 minutes, and then it wears off again. So they wanted to capture that whole thing with both fMRI and EEG. So they had no option really to do it together. So they were doing people wired up to an EEG cap while they were in the MRI scanner as well, and tripping on DMT. It's a kind of amazing work. That's Chris Timmerman's work at Imperial.
Yeah, that's super interesting how they're able to pair the fMRI with different types of imaging modalities and be able to look at it, look at the participants or look at the patients from many different angles all at the same time. And yeah, I can definitely see all those data streams that you talked about, right from the fMRI machine being useful in various different research approaches or various different studies. And then, yeah, I can also see it being useful paired with the PET scan, as you mentioned, or the EEG. I'm especially interested in pairing it with the EEG because then you're getting high spatial resolution from the fMRI and high temporal resolution from the EEG. And I think that's a very powerful pair to be able to get high
Yeah.
resolution in both directions.
If you're interested in fast events, yeah, then EEG fMRI is the way to go. For me, because I'm mostly doing kind of drug related work. I like the combination of PET with MRI, because with PET you get the kind of molecular level information. PET's a molecular imaging technique, right? So it's focused on particular receptors in the brain and that kind of thing. So when you do a PET scan, you can see where your drug is binding in the brain and how much of a proportion of the receptors in the brain it's taking up and things like that. So for me, I'm always keen to build that bridge between the kind of molecular level and the functional level of these drug effects, if you like. So okay, we're giving people a psychedelic, we're seeing it binds to this particular receptor in the brain, but then how is that producing these really strong effects on brain organization and consciousness and things like that?
Yeah, absolutely. And it makes a lot of sense how that bridge would be super important, especially for the drug and pharmacology related work that you've been specializing in. And to make a small pivot, I read some papers recently regarding fMRI based brain computer interfaces. And as an fMRI specialist, I was wondering if you had any thoughts on those.
Yeah, I mean, people have been kind of trying this for a long time. So, I don't know, 10 years ago, there was some work showing that you could train people to basically play a game of Pong. You know, Pong, the old game with the little paddles that move up and down the screen and you bat a tennis ball back and forth. So you can train people to modulate their brain activity in such a way that they can move this little paddle up and down on the side of a screen. And if you had two people in two MRI scanners kind of side by side, and they were hooked up right, they could play a pretty slow game of Pong just with their brains. So yeah, and that's the kind of basis of kind of fMRI based brain interfaces, I guess. You're scanning somebody and they're deliberately changing their brain activity in order to produce some kind of effect that you can detect, and then you use that to control something. I think the problem with that, I mean, problem with fMRI is it's slow, right? You're basically the signal you're recording with fMRI is related to blood flow. So you change the activity in one bit of your brain, that bit of your brain requires more oxygen and more nutrients from the blood, and you get a change in blood flow in that area. And that's the signal that we're detecting with fMRI. But that change in blood flow takes a few seconds after the area becomes active. So it's a slow signal. So it's okay for playing a very slow game of Pong or something like that. But there's probably more work happening on the EEG side with that kind of thing, I would think. Then there's Elon Musk, who wants to implant electrodes in people's brains and things like that. I don't know how that's going to go.
Yeah, and I guess another issue with fMRI when it comes to like using it for a brain computer interface is if some people can't really take it home with them since these fMRI machines are so big, they're not portable, they're very large, very expensive, and in many cases very dangerous if you have metals or things like that around.
Yeah, that's a problem. I mean, that is the real downside of fMRI, frankly. It's big and it's expensive and it's not very portable. And you have other things like EEG, or people are starting to get excited about other technologies like fNIRS, functional near infrared spectroscopy. There's this new company called Kernel that have built this kind of helmet that you can, which looks a bit cumbersome, but it basically works okay. Um, uh, for recording that kind of data. That's a similar kind of signal that you're looking at. That's just shining infrared light through the skull and looking at blood flow. So that's a similar kind of signal to fMRI. There's portable MEG systems now, magnetoencephalography, which people are working on. People are actually working on low magnetic field MRI scanners as well, which would be much easier to work with. So the reason why MRI scanners are so massive is because to get those super strong magnetic fields that you need to have a superconducting magnet. And to get a superconducting magnet, you have to cool the superconductor down to nearly absolute zero, right? So most of the bulk of an MRI machine is this pressure vessel, which is full of liquid helium, which is cooling the thing down. And obviously you're dealing with, things at near absolute zero. You need to have loads of pressure gauges and a pressure system to keep the thing cool, and that's why it's so big and cumbersome. If you could use a permanent magnet, so a non-superconducting magnet to do this kind of stuff, then MRI machines could be much lighter and more portable. And a lot of people are working on that, so doing MRI with quite low strength fields. And the AI thing is going to be really useful there because you get fairly crappy images from those low strength magnetic fields, but then maybe we can kind of punch them up a bit using these deep learning networks and actually get the quality up a bit.
That seems like it could be a great pairing, a more portable fMRI with maybe a weaker magnetic field paired with this AI and deep learning that maybe it's not like clear images like we can get from a lab, but maybe it would at least be clear enough to be usable in some manner. And
yeah, I mean the idea is that eventually we'll have a kind of bedside MRI, something that we can on a trolley that we can wheel up to a patient's bedside, stick their head in it, and we'll be able to get a reasonable image like that.
I think that would be incredible. And this kind of brings me into the next question I had, and that's, do you have any predictions for the field of neurotechnology over the next 20 years? And, both from a zoomed in perspective, looking at your specific subset of the field, like fMRI, which we've been talking about a little bit, and then also zooming out and looking even across the broader field at large.
Sure. I mean, making predictions is always tough, right? Because they're
Yeah.
never right. They're never right, but it's still fun anyway, isn't it? Wow. I seem to keep going on about AI, but I mean, I think that really is going to change everything, and I think we're only at the beginning of what it can do. And it's so hard to predict exactly how it's going to impact things, because I think the impacts are going to be so huge that it's I don't think we can imagine the scope and the depth of at which that's going to have an impact on everything. So yeah, that's a rubbish prediction, because of course AI is going to change everything. In terms of the kind of stuff that I do, I think it's kind of an exciting time, because for a long time, people have had this ambition of neuroscience based diagnosis of particularly, psychiatric disorders. Okay. So this is a real problem. we're pretty sure that psychiatric disorders like depression, anxiety, schizophrenia, ADD, whatever, we're pretty sure they all happen in the brain, because where else could they be? And we've got all this fancy brain scanning technology, but up until now, we haven't actually been able to find, a broken bit of brain, which means that this patient has schizophrenia. We haven't managed to derive kind of imaging-based biomarkers like other fields have derived. So, for instance, a patient goes to their doctor, they have a blood test, the doctor can run that blood test through a certain set of screens. If there are certain protein markers in the blood, the doctor knows that patient has cancer. It's very, very simple, very clear, right? There are certain protein markers that will only be in the blood if that patient has cancer, and then the patient can get the treatment they need. That's a really simple and clear biomarker. And obviously it took 30 years of effort to actually develop that. 30 years of effort and research, but we don't have anything similar for psychiatric diseases. We people have been looking for years for imaging based biomarkers. Can we scan a patient with schizophrenia and look at their brain and say, okay, well, this is why you have schizophrenia? And you can do it. Okay, you can take 100 people with schizophrenia and 100 healthy controls, and you can scan their brains and you can look for differences, and you can find some. There was thinner gray matter in the prefrontal cortex in schizophrenics or whatever. Okay, but then the areas of overlap between those two groups are so wide that for any one particular patient, that's not a strong enough kind of diagnostic marker. So this is, sorry, I took a long way around to get to this point. I think we're kind of at the point now where we are starting to make some inroads into that problem. Maybe not for diagnosis, but I think we are starting to be able to say, or to get to the point where we might be able to at least recommend different treatments for people based on their brain function. For instance, in depression, we might be able to say, in a few years' time, we might be able to say to a patient, we're going to take you in for a scan, and we're going to recommend, based on the scan, we're going to recommend this particular drug. There's loads of antidepressants. People generally get started on one antidepressant and it doesn't work, and they switch to another one and that doesn't work, and then they switch to another one. Oh, maybe that one works. Great. In the meantime, that's been a year of their life when they've been taking these medicines and having side effects, and things are not working, and going back to their doctor and so on. Right. So even if we can cut that down from a year to 6 months, with trying these different treatments based on brain scans, that would still be a really useful thing. And I think we're getting to the point now where we might be able to do things like that. So derive some useful biomarkers from these imaging data. And a lot of that, I think, will be related to what's called dense sampling. There's a kind of a movement now in the fMRI space to do really long scans and get a lot of data from individual people. There was a point a few years ago when we were, well, let's get data from like 10,000 subjects. And now people are coming around to the idea that, well, maybe we should not get data from 10,000 subjects. Maybe we should scan just one subject for 10 hours, rather than half an hour, and get really good data from this one subject. And people are doing that and getting some really interesting effects and showing some things that you can't see if you've only got a 10-minute scan from this subject. You can see quite a lot more in 10 hours than you can in 10 minutes. So I think that's an interesting innovation, and I'm hopeful that we can get to the point where we actually can make some differences for patients with this stuff.
Yeah, I'm hopeful as well. It sounds like some of these things that you were talking about could really be game changers. For example, those biomarkers, either for diagnostic or treatment purposes, could really speed up getting people to the right treatment or to the right diagnosis so much faster. And I think that could really be helpful for quality of life. And then Additionally, the work on I think you called it dense imaging or
Dense sampling, yeah.
yeah, dense sampling. That
Mm.
also seems super interesting because the people probably are going through lots of different brain states while they're across the 10 hours, much more than they would be going through in the 30 minutes. And you can kind of compare in that same person the brain states across time and across that day. So that seems like another really exciting and perhaps very useful innovation in the field. And I don't think I had any additional specific questions for you today, but I did want to ask, can the listeners contact you for further discussion after the episode? And if so, how can they reach out to you? And who should reach out to you and what kind of topics should they reach out to you about?
Sure. I mean, I'm always happy to talk to people about this stuff. I mean, yeah, I'm a massive nerd about this stuff. I like talking about it. Yeah, you can find me on Twitter or X as it's called now. I'm on Blue Sky as well. I mean, you can Google my name, or maybe we can put some links in the show notes or something like that. Um, but yeah, if you want to contact me on there, that's totally fine.
Yeah, sounds good. And yeah, I can definitely put those links in the show notes. And I really appreciate you taking some time out of your day to talk with me today. It's been an incredibly interesting episode, and I feel like you taught me a lot, and you got me really excited about the fMRI space.
Thanks for inviting me. It's been really great. Thanks.